Hello students, we all know that health is wealth. In fact, it is life itself. So the importance of health as a global social goal cannot be exaggerated. And even the poorest developing country must make an effort to invest in the health sector. Yet, there are challenges to health worldwide. Healthcare institutions across the world are facing challenges in the delivery and provisioning of services with financial solvency. Patient care now competes with the financial solvency of the healthcare institutions, and the issue of ethics has become more relevant than at any other point of time, especially with the outbreak of the global pandemic to which we are all witness. Healthcare services have a special moral quality. Few people can be morally comfortable with the idea that some people should be denied access to health care that might relieve their suffering or save their lives because they are unable to afford it or pay for it. Unfortunately, health in India has been an issue that our policymakers have tried to grapple with since the time of India's independence. In the Indian context, health indicators are poor. The discourse on ethics assumes therefore greater complexity and requires a more nuanced understanding and appreciation of the contextual elements. The health indicators of India have consistently lagged behind the economic development that has been witnessed over the last decade, and the need for increased investment in healthcare has been acknowledged all across the country. So what is the scenario so far as health or public health in India is concerned? Only 23.5% of the urban population and 30.6% of the rural people choose government facilities, thus reflecting the widespread lack of confidence of the people in the public healthcare system. Private healthcare is highly fragmented, with over 90% of private healthcare being serviced by the unorganized sector. 80% of the private hospitals are small clinics and nursing homes. 6 to 7% are 100 to 200 bed size hospitals, and only 2 to 3% of the hospitals are 200 plus bed. Most of the large hospitals are located in the urban areas. The sector, however, has attracted considerable private investment, and it appears that the participation of the private sector in this field is likely to continue in the near future. India's rank in the Human Development Index Report 2018 shows that India is 130 in a number of 189 countries. It is one of the fastest growing economies of the world. The very essential components of primary health care, namely promotion of food supply, proper nutrition, safe water, and basic sanitation and provision for quality health information concerning the prevailing health problems, all these are largely ignored. Access to healthcare services, provision of essential medicines, and scarcity of doctors are some of the other bottlenecks in the primary health scenario in India. So what ails public health? From the start, the public health system was marked by all the characteristics noted for the schooling system in India: low funding, poor spread in rural areas, substandard infrastructure with islands of excellence, and of course paucity of staff. Again, the universality of the program was denied in practice by non-availability, by the middle and upper classes opting for private health facilities and practitioners, and by doctors trained in governmental institutions opting for the private sector, preferably in another country. In addition, as population control became a principal development strategy of the Indian state, allocations for health, especially for women and children, were increasingly invested in family planning programs, family welfare being the euphemism. This made even the poor wary of public facilities. On top of that, there has been the impact of liberalization. The neoliberal disposition of the government advised institution of user fees and the rising costs of medicine with public institutions following market deregulation have further meant that for the poor there is often little difference in cost between public and private health institutions. What has been the impact of affirmative action on health thus far? The National Health Policy emphasizes the role of affirmative action in achieving health equity for a range of excluded groups. On the whole, the available empirical evidence regarding the uptake and impact of affirmative action policies is limited. Reservation policies in higher education and electoral constituencies have had a limited positive impact in enhancing the access and representation of minorities. However, reservations in government jobs remain poorly implemented. In general, class, gender, and location intersect, creating inter- and intra-group differentials in the impact of these policies. Several government initiatives aimed at enhancing the access of religious minorities to public services or institutions remain poorly evaluated. Clearly, there is need for proper future research. Future research and practice need to focus on the neglected but relevant research themes such as the role of private sector providers in supporting the inclusion of minorities, the political aspects of policy development and implementation, and the role of social mobilization and movements. Evidence gaps also need to be filled in relation to information systems for monitoring and assessment of social disadvantage, implementation and evaluative research on inclusive bodies, and understanding how the pathways to inequities can be effectively addressed, because the whole focus is on achieving health equity. So, inequities need to be highlighted and unearthed. Unlike education, health is not a fundamental right in India. Although Indian courts have interpreted the right to health as part of Article 21 of the Constitution that guarantees the right to life and personal liberty. Consequently, there is no legislation that makes the right to health a justiciable right for which remedy can be sought in a court of law. There was a proposal to do so as part of the draft of the National Health Policy under discussion in the year 2015. However, it was dropped in the final policy that was adopted in 2017. Several healthcare program schemes exist that broadly target people living below the poverty line as well as people in rural and in difficult to reach locations. These groups contain a disproportionately higher representation of ethnic and religious minorities. Furthermore, the reservations in medical education as well as the presence of minority-administered institutions operating in medical education should, in principle, enhance the representation of marginalized groups in healthcare workforce. Studies indicate that the discrimination in public healthcare delivery based on caste and social groups is a reality. There is underrepresentation of healthcare workers from marginalized social groups, more so in the cadres of physicians and surgeons. There is therefore need to involve the marginalized groups in healthcare. This is shown to be one of the factors that contribute to an environment leading to discrimination in health delivery in India. In fact, Drez and Sen observed that one of the factors behind the better utilization and performance of the public health system in Tamil Nadu is narrowing of social distance between doctors and patients with the recruitment of several doctors who are women and those coming from the marginalized social groups. More recently, the national government and several state governments have developed government-funded health insurance initiatives targeting the poor and occasionally other vulnerable communities. These initiatives have substantially enhanced insurance coverage among poorer sections of the society. Mention may be made of the Rashtriya Shasthra Bima Yojana, which has covered 36.3 million households of a total of 59.1 million households living below the poverty line as early as 2017. But there are lacunae in governmental insurance. Recent studies point out that the scheme has not made any significant reduction in the incidence and the extent of out-of-pocket payments. These government-funded insurance schemes offer financial protection against hospitalizations but do not cover outpatient services. Studies also reveal that the target households face barriers at various stages from enrollment to making insurance claims of availing benefits under the insurance schemes. Further research is needed to evaluate the inclusion of minority, ethnic and religious groups within these schemes. Mention must be made of the National Health Mission. The Union Cabinet, via its decision in 2013, approved the National Urban Health Mission as a submission of an overarching National Health Mission, with National Rural Health Mission being the other submission of the National Health Mission. State-specific innovations will be encouraged. Process and outcome indicators will be developed to reflect equity, quality, efficiency, and responsiveness. Targets for communicable and non-communicable disease will be set at the state level based on local epidemiological patterns and taking into account the financing available for each of these conditions. The National Rural Health Mission seeks to provide equitable, affordable, because please remember that rural health is paler compared to urban health in India. So, the National Rural Health Mission seeks to provide equitable, affordable and quality health care to the rural population, especially the vulnerable groups. The mission is an articulation of the commitment of the government to raise public spending on health from 0.9% of the GDP to 2 to 3% of the GDP. It aims to undertake architectural correction of the health system in India. So, what is the thrust of the NRHM? Under the scheme, the Empowered Action Group states as well as northeastern states, Jammu and Kashmir and Himachal Pradesh have been given special focus. The thrust is on establishing a fully functional, community-owned, decentralized health delivery system with intersectoral convergence at all levels to ensure simultaneous action on a wide range of determinants of health such as water, sanitation, education, nutrition, social and gender equality. Institutional integration within the fragmented health sector was expected to provide a focus on outcomes measured against the Indian public health standards for all health facilities. There is clearly need for integration between the centre and the states in living up to these aspirations. The National Health Mission provides a broad conceptual framework and the states would project operational modalities in their state action plans. During the short period of its existence, it seems that the mission is moving in the right direction, and that is definitely an encouraging development. The central government budgetary outlay for health has been increased, and the state governments are also making the matching increase of 10% in their budgets. Therefore, a process of reforming and strengthening the state health systems need to go hand in hand with the increase of fund flows. There are various schemes that deserve mention under the National Health Mission. The Reproductive, Maternal, Newborn, Child and Adolescent Health Program essentially looks to address the major cause of mortality among women and children, as well as the delays in accessing and utilizing healthcare services in India. It also introduces new initiatives like the use of scorecard to track health performance and other such early interventions which can help control of diseases and deficiencies among children and adolescents. The Rashtriya Bal Shastra Karyakram is an important initiative aimed at early identification, early intervention for children from birth to 18 years to cover 4 Ds, that is defects at birth, deficiencies, diseases and development delays including disability. Early detection and management diseases including deficiencies bring added value in preventing these conditions to progress to its more severe and debilitating forms. There is the revised National TB Control Program, which is a state-run tuberculosis control initiative of the Government of India with a vision of achieving a TB-free India. National Leprosy Eradication Program was initiated by the government for early detection through active surveillance by the trained health workers and to provide appropriate medical rehabilitation and leprosy ulcer care services. The Pulse Polio is an immunization campaign established by the Government of India to eliminate polio in India by vaccinating all children under the age of 5 years against the polio virus. The Pradhan Mantri Swasthya Suraksha Yojana was announced with objectives of correcting regional imbalances in the availability of affordable and reliable tertiary healthcare services and also to augment facilities for quality medical education in the country by setting up of various institutions like AIIMS and upgrading government medical college institutions. The other schemes that deserve mention under the NHM also include Integrated Child Development Service, which was launched to improve the nutrition and health status of children in the age group of 0 to 6 years, lay the foundation for proper psychological, physical and social development of the child, effective coordination and implementation of policy among the various departments, and to enhance the capability of the mother to look after the normal health and nutrition needs that proper nutrition and health education demand. Rashtriya Shasthya Bima Yojana is a government-run health insurance program for the Indian poor. It aims to provide health insurance coverage to the unrecognized sector workers belonging to the below poverty line, and their family members shall be beneficiaries under this scheme. Such a scheme is important particularly because poverty can often be an important impediment that prevents access on part of many to healthcare facilities. And that is why the Indian Union budget of 2021-22 acquires attention. The Indian budget of 21-22 was all about reviving the economy that got severely hit by the unprecedented pandemic. To bring the country back on track, the focus has been laid on healthcare and infrastructure with an eye on achieving the vision of Atmanirbhar Bharat. Of the 6 pillars of the budget proposed by Finance Minister Nirmala Sitharaman, the very first is based on health and well-being. This was much on the expected lines post the outbreak of the COVID-19 pandemic. What is noticeable about the budget is that for the first time we see and witness a tremendous increase in the outlay so far as health is concerned. For many years, experts have been unequivocally demanding an increase in public spending on healthcare to improve health infrastructure and that of the allied industries, but very little has been achieved. As per National Health Profile data of 2019, India spends just over 1% of its GDP on public health, which is drastically low considering the country's population, demographics, and ever-increasing disease burden. In light of this, the Finance Minister's allocation of Rs 223,846 crore towards healthcare, a whopping 137% rise from the budget last year, is worthy of applause. But while these budgetary supports of course are important and necessary, the question is, are they sufficient? Despite the gung-ho around increasing the healthcare allocation considerably, the fact can't be brushed aside that some budgetary supports are only meant for one time, such as the Finance Commission grant of Rs 13,000 crore and earmarking of Rs 35,000 crore for COVID-19 vaccination efforts. The allotted budget of Rs 21,158 crores for water and sanitization is also bundled in the healthcare outlay, resulting in the overall 137% hike. enhancing healthcare infrastructure in the country requires more than just one-time support and far more concerted efforts to meet the committed increase in healthcare spend to 2.5% of the GDP by 2025. The current budget is, of course, as I said, a good start in the right direction. The present budget of 2021-22 so far, as affirmative action in the domain of health is concerned, is a good start in the right direction. Even if the increased allocations are more than that meets the eye, it is still a welcome start. The pandemic in many ways was a wake-up call towards particularly investing in research and development, immunization, nutrition programs, and preventive and curative health care. It drew attention of the government towards the fragile healthcare infrastructure that we have and the gaps in the sector that need to be filled up to revamp the overall system and to make healthcare more accessible and more affordable. Therefore, affirmative action in the realm of healthcare in India definitely has a long way to go. The realization has dawned upon the government, better late than never, but nonetheless it has dawned that this is one sector which can hardly be ignored for the future of India. Thank you.